Hey there, welcome to our NCLEX-RN review on gastrointestinal disturbances, part 1 on common stomach issues such as gastroesophageal reflux disease, gastritis, peptic ulcers, and hiatal hernias. Take note that these are super important for you to review what goes on in the upper gut and the related patient care. And getting these down will really help you ace your exam and be awesome at your job. So let's dive in and learn them together. So our first topic here is about GERD. And so this is something that will occur when the stomach acid, food, or even the bile can flow backward from your stomach into the esophagus. And normally there's a barrier between the stomach and the esophagus. We call that as the lower esophageal sphincter, or the LES. But when this barrier doesn't work, reflux happens. And this backflow can cause irritation and lead to symptoms like heartburn. Now, we will talk about the causes, and there are several things that can cause GERD. The first one is what we have as the incontinent lower esophageal sphincter, or LES. And this is that ring of muscle that usually will keep the contents of the stomach from flowing back into the esophagus. If it's weak or if it doesn't close properly, that backflow happens and GERD develops. The next cause here is the pyloric stenosis. This is what we have as the narrowing of the opening between the stomach and small intestine, which is the pylorus. And when it's narrowed, it can slow down the stomach's emptying process. It can cause pressure and reflux into the esophagus. Now, the third one we have is the gastric outlet obstruction, which is quite similar to the pyloric stenosis, but it can increase pressure. It can promote acid reflux. Another one is the hiatal hernia. It will displace the LES. It will impair its function and contribute to GERD as well. Now, another is the motility disorders, and these are scleroderma, could be esophageal spasms, and these issues can actually cause the muscles of the esophagus to not contract properly or move food properly. And if the food doesn't move along as it should, the pressure can cause acid to back up into the esophagus. Now we have the diet. So the mnemonic catch. This represents coffee, alcohol, tobacco, chocolate, high-fat foods are the items that can worsen GERD by relaxing the lower esophageal sphincter, or it can also increase acid production. Now we have the risk factor, which is going to be obesity. So if a person carries extra weight, especially around the abdomen, it puts more pressure on the stomach, and this added pressure can force stomach contents upward into the esophagus, which will cause the reflux. Now, this time we will be talking about the different clinical manifestations, and these are somewhat very common. You might have already experienced this. One is the heartburn, which is that burning sensation in the chest or the throat, often after eating or when you start lying down after a huge meal. Another is the regurgitation or the epigastric pain. This is very common, and same thing with the chest pain. What is going on here? Well, sometimes for some individuals, sometimes it can be mistaken for heart-related issues, and this can occur due to the acid irritating the esophagus. We also have chronic dry cough because the acid reflux can irritate the throat, leading to a persistent coughing. There's also nausea and also odynophagia. This is going to be the painful swallowing. And this might indicate esophageal damage, or let's say stricture, and that globus sensation, that sensation that there is something stuck in your throat, and there's also hypersalivation. And the common complications that we have known so far are the following. One is the esophageal stricture formation, and this can make the swallowing difficult. It can cause the food to become stuck in the esophagus. And this complication will require interventions such as dilation or stretching of the esophagus or surgery in several cases. And untreated strictures can further lead to some nutritional difficulties or possibly increased risk of food impaction. Now we have ulceration of the esophagus, and this occurs due to prolonged acid exposure, which can result in pain, could be bleeding and infection. And we have also aspiration and pneumonia. This is going to happen when the stomach contents, including acid, are inhaled into the lungs. It can cause inflammation and infection, leading to aspiration pneumonia. And this is a serious condition, especially for those patients who have recurrent reflux or in those with compromised swallowing mechanisms. Now we have another complication we call as the Barrett's esophagus. This is something that can occur when chronic acid reflux causes changes in the cell of the esophageal lining, which can become precancerous over time. And this is strongly associated with adenocarcinoma of the esophagus, a type of cancer that can develop in the lower esophagus. And though early detection through regular screening, such as endoscopy, is going to be important into preventing the progression to cancer. Now, this time we'll be talking about the different diagnostics that will be so important in diagnosing this disorder. Well, but routine diagnostic testing is not typically required for somewhat kind of simple or maybe uncomplicated GERD cases, and treatment can proceed directly. However, in some cases, evaluations are necessary for unusual or maybe severe or treatment-resistant cases. And if alarming signs like low blood counts or maybe an intended weight reduction or swallowing difficulties are present, and of course, endoscopy will be warranted when this happens. Now, on top of the diagnostics, here I have included the history, which is basically going to be the initial step, especially in the diagnosis of uncomplicated GERD. And this is based on typical symptoms, could be from heartburn, acid regurgitation, and routine diagnostic testing is not usually needed for simple cases. Now, to proceed here, we have endoscopy, specifically the upper endoscopy, which is going to visually examine the esophagus for, let's say, inflammation or maybe lesions or erosion. It can also allow for doing, let's say, a biopsy, maybe to confirm the diagnosis, especially if symptoms suggest complications caused by maybe Barrett's esophagus, or if there are alarming signs like low blood counts, unintended weight loss, or maybe difficulty in swallowing are present. Now, in preparing the patient for an upper endoscopy, this will require, of course, allowing the patient to fast for about 6 to 8 hours before the testing. And this is going to call for signing of the consent. And this procedure is usually going to involve sedation. And this is administered to help the patient remain relaxed during the procedure. And so around this time, there's going to be some need for adjustment of medications. And the patient here needs to open up, inform their healthcare provider about medications they are currently taking, especially anticoagulants or sedatives, which may need to be paused before they do this upper endoscopy. Now, part of the care here after the procedure, the patient will need to at least require some time to recover from the sedation and should be accompanied home if they were sedated. And this is in a case of an outpatient type of upper endoscopy. And so we're going to have to observe the patient for some complications, and maybe in a form of, let's say, maybe not a complication really, but maybe a sore throat. This is going to be a discomfort that is common for this type of procedure, but generally it will resolve within the day. And for the complications that I'm talking about here, they need to seek medical attention right away if they experience some form of severe pain into their oral cavity or maybe abdominal pain, if they develop fever or difficulty breathing after the procedure. These are things that you need to teach your patient to report to the medical provider right away. Now, another procedure that will be done is the esophageal manometry. And this is a test that will measure the pressure of the lower esophageal sphincter, or the LES. It can also evaluate the function of esophageal peristalsis, which are the wave-like contractions that help move food down the esophagus. And this test is very useful in assessing the motility disorders or to evaluate the function of the LES in GERD. Now, to prepare the patient for this procedure, they need to be on fasting mode for about 8 to 12 hours, and no medications should be taken right before the test, such as the proton pump inhibitors, antacids, for at least 24 to 48 hours, unless it's instructed by the medical provider. Now, this is a type of procedure that involves a placement of a tube being passed through the nose into the esophagus, so patients may want to use a saline nasal spray to clear the nasal passages before the test. And again, this is an invasive procedure. Make sure that they have to sign the consent. Now, after the procedure, they're going to have to complain of some sore throat or maybe discomfort, and this is common. Usually that will resolve within a few hours. You're going to make sure that hydration will be encouraged to help alleviate any lingering throat discomfort, and make sure that the healthcare provider will discuss the results with the patient, which may lead to further testing or maybe some treatment adjustments. Now we have another testing here, which is the Bernstein's test, or the acid perfusion test. So what is this? This is a testing that is used to differentiate cardiac from non-cardiac chest pain in patients with chest pain that may resemble GERD. And this is going to involve instilling of an acidic solution into the esophagus to reproduce the symptoms and also confirm the patient is related to the acid reflux rather than heart-related causes. Now, to prepare this patient, they should at least fast for at least 6 hours and should hold taking antacids or the proton pump inhibitors, such as the pantoprazole and esomeprazole, and the H2 receptor blockers. And again, the reason for that is to stop this medication that will affect acid production or motility for a specific period before the testing. Now, after the procedure, you need to observe the patient for any kind of discomfort or maybe symptoms that occur during the test, and you might expect some reports that they will have some mild throat irritation or maybe a burning sensation that may happen, but you can tell the patient that these can resolve quickly after the procedure. Now, another testing is the ambulatory 24-hour pH monitoring, and this is going to confirm GERD in patients who are non-responders to the standard therapy, such as the proton pump inhibitors. And so the Bravo pH capsule system, which allows for catheter-free monitoring of the esophageal pH levels for 24 hours, will provide a more accurate measurement of the acid reflux episodes. And so here, you're going to prepare the patient by keeping them in a fasting mode for at least 6 to 8 hours before the test, and also to recommend, or you're going to teach the patient to stop taking the acid suppressing medications such as the PPIs, H2 receptor blockers, and antacids for several days prior to the test, because these medications are known to interfere with the results. Now, for the post-test care, there's going to be a need for you to incorporate in the teaching that there's that capsule detachment that will naturally detach itself after 1 to 2 days, and this will pass through the digestive system. And when the patient will experience maybe some slight discomfort from the catheter or capsule insertion, this will typically resolve after the procedure. Now, the results of the test will be reviewed and treatment will be adjusted based on the findings. Now, the last test that we have here is the barium esophagography, and this is not typically used to diagnose GERD, but it is helpful for evaluating motility disorders or maybe structural abnormalities in the esophagus. And this is a test that will involve swallowing a contrast agent, barium, and a series of x-rays will be done to assess esophageal function and also to detect any narrowing or abnormalities. Now, for you to prepare this patient, make sure that you teach the patient to fast, avoid any liquids, fluids for at least 4 to 6 hours before the test. And you also need to teach the patient to inform their provider of any allergies or medical conditions that may affect the use of the contrast agent. Now, after the testing, it's very important that you're going to have to encourage the patient to increase hydration, especially if they're ambulatory or in the ambulatory setting. They should be drinking plenty of fluids to help clear the barium from their GI tract. Now, take note that the stool appearance will appear white or light colored for a few days due to the barium, which is expected. So this is a part of your teaching for the patient that will be undergoing the barium study. Now, you have to really tell the patient to watch for so many complications, to contact their healthcare provider if they experience abdominal pain or maybe bloating or difficulty passing the procedure. And in some cases, they will be getting a prescription to take in a laxative or stool softener right after the procedure in order to manage the possible complications of the barium study. Now, this time we'll be talking about the different treatment options or management of the GERD. And so here we have the goals of the treatment is to basically to relieve the symptom and also to heal esophageal damage and also to prevent further complications and also relapse of the GERD. Now, part of the treatment here will be the lifestyle modification. So this is going to really ask the patient, or they need to make sure they raise the head of the bed by 6 to 8 inches. And they need to be taught in avoiding lying down for at least 2 to 3 hours after meals. And regarding their diet, they're going to be following a bland diet, avoiding garlic, onions, peppermint, fatty foods, maybe chocolate, coffee, citrus juices, cola, tomato products, and the catch diet that I mentioned earlier. And they need to avoid overeating and tight-fitting clothes as well. And they need to be taught about starting to losing some weight and to also stop smoking, and together with the reduction in their alcohol consumption. These are very important in managing their lifestyle. Now, we have the following pharmacological treatment. Of course, we have the antacids, which are the basic medications that will be part of the therapy. And we have the following. We have aluminum compounds, could be the magnesium compounds. We have the Maalox, magnesium hydroxide as part of those. And these medications work by neutralizing the stomach acid, which will help reduce the acidity of the stomach. And so when these medications react with gastric acid, they're going to form that neutral salt or salts that are only weakly acidic, and this will help reduce the irritation and discomfort caused by the excessive stomach acid. And some antacids not only neutralize acid, but they're also going to reduce the activity of pepsin, which is an enzyme that can contribute to the ulcer formation. However, for optimal effectiveness of the antacids, they need to be taken at regular intervals, and some require doses after meals to counteract acid production during digestion and before bedtime to manage nighttime acid reflux or heartburn. And there's going to be a need for consistent use to ensure a more effective reduction in stomach acid levels. Now, for antacids to work most effectively, they need to increase the stomach acid or stomach pH to a level of above 5. And in a pH of 5 or higher, this will reduce the acidity of the stomach, which can help relieve the symptoms of the GERD, could be peptic ulcer, and other acid-related conditions by reducing the irritation caused by the excess acid. Now, to ensure that the antacid works effectively, tablets should be chewed thoroughly before being swallowed, and this will help the medication start acting sooner. And following with water or milk can also help to spread the medication throughout the stomach and can also soothe the stomach lining. Now, there are also some liquid forms of antacids that are available. It can be easier to swallow or for some individuals, and they tend to act faster than tablets because they're already in a liquid form, which will allow them to mix quickly with the stomach acid and begin neutralizing it more rapidly. Now, we have the next classification, the gastric protectants. And an example here is the misoprostol, which is going to protect the stomach lining by reducing the amount of stomach acid produced while also promoting the production of substances that help protect the stomach lining. And this is going to protect the stomach from the damage caused by NSAIDs, aspirin, which can lead to the development of gastric ulcers. Now, this is a medication that is supposed to be taken with meals or food to reduce gastrointestinal side effects and also to ensure it works effectively while the stomach is processing the food. Now, take note that you have to teach the patient that it can also cause some side effect. It can lead to gastrointestinal discomfort. It can lead to diarrhea, abdominal pain. And this is something that is contraindicated for use in pregnancy. Take note. You got to pay attention here. This is contraindicated in pregnancy because it can cause some contractions of the smooth muscles, especially the uterus, which can lead to miscarriage or birth defects. Now, we have another gastric protectant. We have the sucralfate, which is also common medication, which will create that physical barrier over the ulcers or maybe the damaged areas in the stomach. It will protect them from the stomach acids, the digestive enzymes such as the pepsin, which can worsen the damage. Now, the sucralfate can be taken in a pill or liquid form and is most effective when taken on an empty stomach. So it can form a protective coating over the stomach lining without interference from the food. Now, this is another medication that may also cause issues. So part of that is a side effect. And it can also impede the absorption of some medications such as sodium, warfarin sodium, could be the phenytoin, theophylline, digoxin. And so this medication should be taken at least 2 hours apart from the medication that I just mentioned. So again, 2 hours apart from the other drugs such as the warfarin, phenytoin, and some antibiotics. Now, we have another classification, have the H2 receptor antagonists or H2 receptor blockers, which will work by decreasing the amount of gastric acid produced in the stomach. And this will also help prevent and treat conditions caused by the excess acid. So this is also used to prevent discomfort or relieve discomfort or heartburn, and also to prevent complications caused by the peptic ulcers. Now, this is also going to be these medications such as the cimetidine. This is something that is supposed to be taken at least 1 hour apart from the other antacids. So take note of that. Cimetidine can be administered in the form of IV or could be oral. So if it is supposed to be taken orally, then it has to be separated at least an hour from any antacids. There is a reason for that, and this is to prevent interference of the absorption. We know that cimetidine and antacids can interact with each other. Now, we have the other H2 receptor antagonists, such as the famotidine, nizatidine. They have similar actions, and of course, these have the same mechanisms and the same therapeutic uses in order to reduce the stomach acid as well. Now, these two medications, such as the famotidine and nizatidine, they do not require food to be effective. So this can be taken with or without food, as the food does not really interfere its absorption or their absorption or effectiveness. Now we have the next classification here. We have the PPIs, or the proton pump inhibitors. So namely, we have omeprazole, pantoprazole, esomeprazole. So you have the suffix zole, azole. So these are your proton pump inhibitors, and they're going to work by reducing the amount of acid produced in the stomach, and this will also alleviate the symptoms associated with acid-related disorders such as gastroesophageal reflux disease and peptic ulcer disease as well, and erosive esophagitis. Now, this is these are medications that are contraindicated in patients who have hypersensitivity to any component of the drug, because this can trigger adverse allergic reactions. Now, take note that these proton pump inhibitors can also lead to side effects such as headaches, abdominal pain, nausea, and these will subside once the medication is discontinued, or if they are not really bothering the patient, they probably would disappear, and usually they're mild that can be easily be tolerated later on. Now, we have the management here, such as procedures in treating the gastroesophageal reflux disease, and part of that will be the Nissen fundoplication. Okay, so what is this type of treatment? Well, this is actually going to be done laparoscopically, and so this is going to involve the wrapping of the upper part of the stomach, the fundus around the lower esophagus, to create a tighter lower esophageal sphincter. And so this is an endoscopic type of procedure. Actually a laparoscopic type of procedure, wherein there is going to be a creation of small incisions in the abdomen or on the abdomen, and a camera is going to be used to guide the procedure. It will reduce the recovery time. It also has fewer risks compared to a traditional open surgery, and the procedure will aim to prevent the reflux of the stomach acid into the esophagus. It will provide relief from the GERD symptoms. Now, the procedure itself will help tighten the muscle at the bottom of the esophagus. Take a look right here and how it's done. So it's basically tightening the muscle at the bottom of the esophageal juncture. And this is a procedure that is typically reserved for those patients with severe chronic GERD who are not really responding well to the meds or maybe lifestyle changes. It's also useful for those patients with weakened LES, which contributes to the acid reflux. Now, another test or procedure that we have is the endoscopic therapies. So we have actually more than one. So part of that is the strata procedure. So what is this? This is also a procedure we call as a radio frequency energy. And so this is going to be applied to the LES in the upper part of the stomach. And so the energy that will be used is going to strengthen the LES muscles by causing controlled tissue injury, which will lead to tissue remodeling. It will also improve the LES function. Now, this is a procedure that is done endoscopically, wherein a catheter is going to be inserted through the mouth and into the esophagus to deliver the radio frequency energy. And this is minimally invasive, and this will typically require no incision. Now, we also have this done as indicated for moderate or severe GERD. And also another test or procedure is a transoral incisionless fundoplication, or what we call as the TIF or a TIF. And so this is going to be done endoscopically through the mouth. It does not require external incisions. It also has much faster recovery and fewer complications compared to the open surgery. Now, the procedure itself uses a specialized device that will be inserted through the mouth to create a valve-like structure at the junction of the esophagus and stomach, which is a little bit similar to the Nissen fundoplication. So let me just zoom this in right here. So This is going to not require any external incisions. It will also restore the function of the LES by folding the stomach around the esophagus. Let's take a look at that one. Now, the use or the significance of the TIF into the GERD is very important, especially if they have a chronic type who are not really responsive to the lifestyle changes or the medications. And for those patients that are seeking a much less invasive type of a procedure, because this is less invasive, it can manage the GERD, and it's successful in treating the manifestations of the GERD as well. Now, again, this is a procedure that will require consent signing and also placing the patient in fasting for at least 6 to 8 hours. Now, we will be talking about the different nursing management and care involved in GERD. So part of that will be to discuss the food items and activities to avoid those CATCH acronym that I mentioned. So again, those food items that can relax the lower esophageal sphincter or irritate the esophagus, such as the peppermint, chocolate, coffee, caffeinated drinks, maybe greasy or fatty foods, sodas, alcohol, nitrates, citrus fruits, maybe tomatoes or tomato-based foods, and smoking. And we need to educate our patient about the potential adverse side effects and possibly medication interactions when they're going to be prescribed with the PPIs, the proton pump inhibitors. And also we need to inform the patient about the medications that may exacerbate the symptoms. And these are the anticholinergics, could be the antihistamines, antidepressants, NSAIDs, aspirin, calcium channel blockers. There's plenty of them. And we also need to teach the patient how to properly take the medication, taking pills with water while they are sitting upright. And also we need to recommend a diet that is low in fat, high fiber, and also to suggest avoiding eating or drinking 2 hours before sleeping. Now, we're going to have to recommend a diet that are going to be smaller portions of meals, more frequent meals to prevent stomach bloating, and also to advise the patient from against wearing tight-fitting clothing, and also avoid eating and drinking 2 hours before sleeping, and to make sure that they're elevating the head of bed at least 6 to 8 inches using blocks or pillows in order to prevent the reflux, and also to advise them to stop cigarette smoking. This is very important, and also to emphasize the importance of weight loss, so to reduce the manifestation. Now, we will be talking about another topic here, which is acute gastritis, which is an inflammation of the gastric mucosa. And so we're going to talk about the different types here. We have the acute and the chronic gastritis. So you will see this table is a very important tool to compare the different manifestations and characteristics. So talking about the cause here, well, with acute gastritis, there is that inflammation of the gastric mucosa, and these are often triggered by the external factors. Could be the use of the NSAIDs, could be aspirin, could be the Helicobacter pylori, which is that bacteria that is known to cause the gastritis, maybe alcohol consumption, smoking, caffeine, maybe extreme physiological stress, maybe we're probably relating this to the shock, sepsis, burns, and these factors alone can irritate the stomach lining and can lead to the inflammation. Now, for the manifestations of acute gastritis, this is often the primary symptom of the abdominal discomfort, right? And the patient will experience that feeling of pain in the upper abdomen. And so they're also going to be anorexia, nausea, and vomiting. And especially where the irritation of the stomach lining is so severe, there's going to be headache as a result of the overall physiological stress or inflammation. There's going to be hiccups. A very uncommon symptom that can occur due to the irritation of the stomach. There's going to be reflux or dyspepsia, which can contribute to further discomfort. Now, as far as the testing here, we have the different workups, such as the upper endoscopy. But let's talk a little bit here about gastritis. And so, diagnostic workup is considered for acute gastritis if there is no positive response after 4 to 8 weeks of treatment. And so if the patient may have, let's say, a mild form of acute gastritis, they usually will not undergo any kind of invasive procedure or some sort of this kind of diagnostic procedure such as endoscopy. Now, the ultrasound, which is another procedure, is also going to be employed if there is some kind of conditions, maybe related manifestations due to maybe gallstones, or maybe to test the patient for the H. pylori, especially to confirm or to exclude if it's going to be a different type of disorder. Now, the treatment for the acute gastritis will include the use of empiric acid suppression. We have the proton pump inhibitors, the H2 receptor blockers, and also the discontinuation of the irritants such as the NSAIDs or maybe aspirin that may have caused the condition. And so if the condition does not improve with acid suppression or after 4 to 8 weeks, then further diagnostic workups, including the other invasive diagnostics, will be done. However, there's going to be a need probably for the antibiotic therapy if the acute gastritis is caused by the H. pylori. And of course, this will include maybe 3 different medications or 4 medications in order to treat the infection. Now, for the complications, in most cases of acute gastritis, with the treatment, complications are rare. However, if it's left untreated or maybe improperly managed, it can result to maybe dehydration caused by the vomiting, renal insufficiency, hemorrhagic gastritis, which also involves bleeding in the stomach and can lead to more serious conditions. Now, in response to the therapy, the acute gastritis often will show rapid improvement with acid suppression and also maybe the removal or discontinuation of the NSAIDs or alcohol. And most patients here will experience relief of their symptoms quickly once the causative factors are addressed. Now, talking about the prevention, it again will call for the avoidance of the known irritants such as the NSAIDs, alcohol, smoking, also managing stress effectively, and also maintaining a very healthy lifestyle, and also being mindful of those substances that may irritate the stomach lining, which will help reduce the risk of acute gastritis. Now, we have the chronic gastritis, and so the known cause of this is the H. pylori infection. Majority of the cases is caused by that, and it may also be associated with an autoimmune gastritis, wherein the body's immune system will attack the stomach lining, leading to an atrophic type of gastritis. And this can result in a loss of stomach acid secreting cells and changes in the stomach lining. And the chronic type of gastritis can be manifested in maybe the same or very similar manifestations. They're going to end up with anorexia, nausea, vomiting, but are less common than in acute gastritis. There's going to be belching, which is a very frequent symptom in chronic gastritis, which is related to excess gas or irritation in the stomach. Now, there's going to be heartburn after eating. That's why I put that as PC. And they will also complain about sour taste in their mouth due to the acid reflux, which is a common issue in chronic gastritis. Now, vitamin B12 deficiency is going to be common, especially for an autoimmune type of gastritis, wherein the body's ability to absorb vitamin B12 is impaired, and this can lead to that deficiency, which can lead to the pernicious anemia. Now, for the diagnostics here, this will include the upper endoscopy with some biopsy in order to assess the gastric lining and also to confirm the presence of inflammation. Also testing for H. pylori. This is the most common cause of chronic gastritis. And of course, biopsy results can also help in identifying the autoimmune components. Now, for the treatment here, there's going to be a need to eradicate the H. pylori with the use of, let's say, triple or quadruple therapy, which is basically a combination of antibiotics and acid-suppressing medication. Now, if that condition is autoimmune in nature, managing the underlying autoimmune condition may also be necessary, and also, of course, with the supplementation of the vitamin B12 is also required in cases whenever there is pernicious anemia. Now, for the complications, this can lead to the peptic ulcer disease, could be gastric cancer, or maybe a mucosa-associated lymphoid tissue lymphoma. And the reason for that is because long-term inflammation of the stomach lining will increase the risk of these complications as well, particularly if the H. pylori infection is left untreated. Now, as far as the response to the therapy, this will really require a much longer term of management here. And this will probably require repeated treatments for the H. pylori eradication, vitamin B12 injections, and also any underlying conditions that could have contributed to the gastritis. Now, as far as the prevention here, early diagnosis is very important, especially early treatment of the H. pylori. And the following nursing interventions that I have summarized here are generally applicable to both acute and chronic gastritis, making sure that we're going to withhold food or fluids until the symptoms subside, and also to introduce or reintroduce, let's say, ice chips, maybe clear liquids and solids as prescribed when the patient has already tolerated, and to monitor for hemorrhagic gastritis. Could be manifested in the form of hematemesis, tachycardia, hypotension, and make sure that you notify the medical provider right away if these following occur. Now, we also need to advise the patient in avoiding those irritants, spicy foods, caffeine, alcohol, nicotine, and make sure that you instruct the patient on the proper use of the medication, especially antibiotics. Make sure that they're going to complete the therapy, also with the use of the other medications, and to educate the patient about the need in adhering to the administration or getting the vitamin B12 injections as indicated, because they really need to have this to prevent pernicious anemia. Now, this time we'll be talking about peptic ulcer disease, and this is a very common disorder that is going to be caused by the deficiency of the mucosal defense mechanisms rather than an excess of the acid. Okay, now we're going to compare here the different types here. We have the gastric and the duodenal ulcer. So let's tackle first about the gastric ulcer. And again, as like I have said, the pathogenesis of the gastric ulcer, it's basically the deficiency in the mucosal defense mechanism. Okay, now as far as the Helicobacter pylori infection, the gastric type of peptic ulcer disease is basically a common occurrence here, with the mechanism here leading to the ulceration involves both direct damage from the bacteria and possibly altered immune response. And so the infection rate is slightly lower in gastric ulcer compared to the duodenal ulcer. So we have here about 60% to 70%. Because other factors, let's say NSAIDs, also play a significant role in the gastric ulcer formation. Now we have the malignancy potential. What is the significance of this factor in gastric peptic ulcer disease? Well, there is a small percentage, about 5 to 10% of gastric ulcers can be malignant, particularly those that do not heal with standard treatment, and this is due to the stomach's higher potential for cellular atypia and metaphasia. It would lead to adenocarcinoma. And so biopsies here are recommended to differentiate between benign ulcers and early cancer of the stomach. Now, as far as the location, take note that there are different locations of the gastric ulcer. So first is the lesser curvature, that is referred to as the type 1, and this is going to occur on the lesser curvature of the stomach. So take a look at it right here. And so this is basically away from the acid secreting area, suggesting a breakdown in defense rather than acid excess. Now we have the second type, which is the lesser curvature and duodenum. So that is the type 2. So this is going to be a combination of gastric and duodenal ulcers, and this is often related to H. pylori and NSAID use. We also have the type 3, which is basically the prepyloric region or the antrum. And so here it's located basically at the bottom of the stomach. And this is near the pylorus, where the acid exposure is so high and often related to increased acid secretion. We also have the type 4 of gastric ulcer, which is located in the proximal stomach or the cardia. So take a look here. It's basically closer to the esophagus and close to the esophagogastric junction, where the protective mechanisms might be less effective or where the bile reflux might play a role. Now, if you're going to ask, what is the age distribution of the gastric ulcer? Well, this is more common in people, older people, let's say older than 40 years and above, wherein the gastric mucosa might be less resilient. And there is also a cumulative exposure to some risk factors, maybe the use of NSAIDs, smoking, chronic H. pylori infection. Now, as far as the risk factors, the following are known. We have smoking, which can impair the mucosal blood flow. It also reduces the bicarbonate secretion. It will also increase acid secretion, all of which can compromise the stomach defense mechanism, and it will lead to the ulcer formation, stress. And we have corticosteroids as well, alcohol, H. pylori as the other risk factors. Now, talking about eating and pain. So, is there going to be relief of the pain with the presence of food? Well, with the case of the gastric peptic ulcer disease, eating might not relieve the pain because the pain can be due to the inflammation or irritation rather than just acid. And so the higher complication rates are due to the stomach's larger size and different vascular supply, which can lead to also lead to this kind of sensation. Now, talking about the duodenal type of ulcer. Now, this is something that is caused by the increase in the offensive factors. So there is going to be maybe increasing gastric acid, overpowering of the protective mechanisms of the duodenal mucosa, and the gastric acid secretion is increased due to maybe several factors, maybe vagal stimulation, could be gastrin release, or maybe some genetic predisposition. And the increased acid can overwhelm the duodenal bicarbonate secretion and also the mucus layer. It can lead to the ulceration. Now, Take note that the role of the acid is crucial, as evidenced by the higher basal and stimulated acid levels in these patients. Now, if you're going to ask, is there going to be high incidence of H. pylori infection in duodenal ulcer? Well, there's going to be about 70 to 90% of H. pylori cases in duodenal ulcer. And of course, we know that the infection can disrupt the normal regulation of the acid secretion. It will affect the somatostatin secretion from the D cells, and it will impair the duodenal mucosal defense. It can lead to ulcer formation in about 70 to 90% of cases. So, now as far as the malignancy potential, there is lower risk, because the duodenum here is less prone to the cancerous changes compared to the stomach, and the environment and cellular turnover in the duodenum do not favor malignant transformation as much as in the stomach. Now, if you're going to ask, what is the location? Well, the duodenal ulcer will usually occur in about 1 to 2 centimeters distal to the pylorus or the posterior wall, due to the acid pepsin attack being more effective here due to the less bicarbonate neutralization compared to the other parts of the duodenum. Now, if you're going to ask, what is the age distribution here? Well, this is something that can occur mostly in younger people, younger than 40 years old, due to a higher acid output in this age group, and possibly due to the lifestyle factors, maybe genetics, and a more robust type of immune response to the H. pylori, which might paradoxically lead to more ulcers. Now, as far as the risk factors, H. pylori infection, alcohol intake, ASA or aspirin, the use of NSAIDs, steroids, caffeine can lead to the duodenal ulcer. And if you're going to ask about eating and pain, the pain in duodenal ulcer is often eased because eating can neutralize gastric acid, providing relief. And also the pain here will occur about 2 to 5 hours after eating. And there is that nocturnal pain due to increased acid secretion at night when there's no food to buffer the pain, or buffer the acid rather. Now, this time we'll be talking about the different diagnostic, or the manifestations here, I should say. So let's compare the different manifestations between gastric and duodenal ulcer. And so we're talking about the pain location here. And so with the gastric type of peptic ulcer disease, gastric ulcer pain will be localized in the epigastric region, which is the upper middle part of the abdomen, but it tends to be more localized to the left of the midline. And this is due to the anatomical positioning of the stomach. Now, as far as the pain character, the pain from a gastric ulcer is typically described as sharp or gnawing, and this reflects the erosive nature of the ulcer on the stomach lining. It can cause more intense cutting sensation. Now, for the pain timing, the pain in the gastric type of ulcer will often occur within 30 minutes to about 2 hours after eating. And this timing is because food can irritate the ulcer directly, can lead to pain as the stomach begins to digest the meal. Now, for the pattern, the pain pattern for the gastric ulcer is characterized by worsening with eating, since the ulcer is in the stomach, and also the ingestion of food can increase stomach acid production, which will further exacerbate the ulcer and increase the pain. Now, for the nocturnal pain is less common with gastric ulcers, and this might be because the stomach's activity decreases at night, reducing the acid secretion that could aggravate the ulcer. Now, if you're going to ask if there's going to be hematemesis in gastric ulcer, yes, this is more common in gastric peptic ulcer disease, and this is because the bleeding from an ulcer in the stomach can mix with the stomach contents and be vomited up. And if you're going to ask if melena is common in gastric ulcer, we know that melena is the passage of the dark tarry stools to digested blood, but it is known to be less common. Again, melena is less common in gastric ulcers, or ulcers compared to the duodenal ulcers, because the blood has traveled through the intestines, getting partially digested along the way. Now, for the duodenal ulcer, the pain location here is also in the epigastric region, but it can radiate to the back. Take note of that. And so the radiation occurs because the duodenum is positioned posteriorly to the stomach. It will allow the pain to travel along the nerve pathways to the back. Now for the character, the pain will be somewhat burning, and the sensation might be due to the acid from the stomach irritating the duodenal lining where the ulcer is located. Now for the timing, it usually can happen about 2 to 5 hours after the meals, and the delay happens because initially food can neutralize the stomach acid, but as the food moves into the duodenum, the protective barrier diminishes, and also the acid can irritate the ulcer. Now for the pain pattern here, this is often relieved by eating, because this relief comes from the food buffering the stomach acid. It will reduce its contact with the duodenal ulcer. Now for the nocturnal pain, this is common in duodenal ulcer. This is because acid secretion increases at night and there's less food to buffer it, leading to increasing pain when the stomach is empty. Now for hematemesis, this is less common in duodenal ulcer. When it does occur, it's because of significant bleeding that travels back into the stomach before being vomited, but again, it's less common. Now for melena, this is more common in duodenal ulcer because the duodenum is further down the digestive tract, and blood from a bleeding ulcer has time to be digested by the intestinal enzymes, resulting in a characteristic black or tarry stools. Now, talking about the other manifestations here, we have the belching, which is the excessive burping. And this is caused by the excessive gastric acid production, which also delays gastric emptying, which will lead to increasing gas in the stomach. And the mechanism here, it's because of the disruption in the normal digestion, leading to the gas buildup and discomfort. Now, another is the dizziness. And this is caused by the significant blood loss from the ulcer bleeding. And of course, with a reduction in the total circulating volume and also decreasing the oxygen delivery to the brain tissues. And we have syncope, which is caused by severe blood loss from a bleeding ulcer and can lead to the fainting episode. Now, if the bleeding is rapid in its onset and it's very substantial, it can lead to a sudden drop in the blood pressure and also reduce cerebral perfusion, causing some loss of consciousness. Another is anemia, of course, in some cases, such as a chronic blood loss from a bleeding ulcer. It can lead to iron deficiency anemia, or what we call as the microcytic type of anemia. Now, if there is going to be slow, persistent bleeding, it can deplete the iron stores over time, and the person will complain about fatigability, pallor, shortness of breath. And when you're going to look into their laboratory reports, there's going to be a drop of the hemoglobin, hematocrit, and also the ferritin levels, which are very commonly observed in patients with a peptic ulcer disease. There's going to be weight loss, and this is often associated with eating in gastric ulcers. It can lead to a reduction in food intake. And in addition to that, nausea and vomiting may also contribute to the weight loss. Now, for those patients who have gastric ulcers, they might avoid eating in order to prevent exacerbating the pain, and maybe some malabsorption or complications like gastric outlet obstruction may also play a role in the weight loss. Now, this time we'll be talking about the different diagnostic tests about peptic ulcer disease. And so on top of the list here is the upper endoscopy, which is basically going to give a much more of an accurate result to directly visualize the stomach and the duodenum, and also will precisely identify all ulcers and the characteristics. And it can also lead to, it can also allow taking of biopsy especially for those ulcers that may help differentiate benign ulcers from gastric cancer. And this is very critical because gastric cancer may initially present with similar symptoms. Now, this is also preferred for the bleeding ulcers in cases of acute or maybe severe bleeding. The endoscopy is not only diagnostic, but it also is therapeutic. And so it will employ the use of cauterization that will help stop the gastric bleeding. Now, the upper endoscopy tests can also detect H. pylori, which is a common cause of ulcers, and this can be done through the histologic examination that is collected through the biopsy, right? Now, talking about the pre-test preparation, you need to make sure that the patient is NPO for at least 6 to 8 hours before they undergo this testing, which will allow much clearer visualization and also reduce the risk of aspiration. Again, consent is supposed to be signed by the patient this time. Now, the patient here is supposed to stop taking a PPI, H2 receptor blockers at least 1 to 2 weeks prior to the procedure. And this is intended when there is a need to test for H. pylori infection. Now, securing consent is top priority, and also make sure that you will be teaching the patient to remove their dentures or maybe prosthetics if applicable. Make sure that they have those removed as well. Now, for the post-test care, you need to monitor for any complications, check for their sedation, and also to check for any signs of bleeding, black stools, vomiting, or blood, or maybe signs of perforation as a complication to the diagnostic procedure. Maybe they're going to end up with a severe abdominal pain. This is something that you should report to the doctor right away if they'll complain such manifestations. Now, as far as the diet, they need to be checked first on their gag reflex before resuming any oral fluid intake or food intake. And often they're going to be started with clear liquids once their gag reflex is intact, and they can usually gradually resume their normal diet as tolerated. Now, as far as the sedation recovery, we need to monitor the patient's sedation status. Advise the patient to not drive if they are in an outpatient type of setting. They are not supposed to be driving after the procedure, and not to make any important decisions for 24 hours. Alrighty. Now, talking about the testing, talking about barium swallow, I have talked about this in a previous topic of gastroesophageal reflux disease. Now, the barium swallow is going to be used as an initial test. It involves the patient about swallowing, drinking a barium-containing liquid that will coat the gastrointestinal lining. And after that, X-rays are then taken to identify the abnormalities like ulcers. However, this is less reliable compared to the endoscopy. Even though the barium swallow can provide an indirect image of the ulcers, but it will not really confirm the diagnosis or rule out malignancy because it does not allow for a biopsy. Now, there is what we call as the double contrast technique, and so this is an advanced method used for both barium and air to improve the visibility of the gastrointestinal lining, so it will make it more accurate than the standard barium study. And so that's again the double contrast technique. Now, what are we going to do for the pre-test here? Well, we're going to have to restrict intake of food and fluids for about 6 to 8 hours. And of course, we're going to have to instruct the patient to remove any jewelry. It might interfere with the imaging study. And after the procedure, we need to monitor the patient for any constipation. And we're going to encourage the patient to take in lots of fluids, oral fluids, and also to take a laxative to help clear the barium from the system, because this can cause constipation and obstipation. Now, also take note that the medication or the barium can make their stools appear white or gray for about 1 to 3 days due to the barium. And they need to make sure report any abdominal pain, because this might be a sign that the barium might have been impacted in the gut. Now, as far as the diet, they can resume normal diet unless otherwise instructed. Now, take note here, we're going to have to also include the laboratory testings for H. pylori. And so this is going to include doing a biopsy. That is also done during the endoscopic type of procedure, and this is going to be analyzed for evidence of H. pylori, and this is considered as the gold standard for detecting the bacteria due to its high accuracy. And so there's also what we call as the stool antigen tests, and so this testing will identify the H. pylori antigens through a stool sample. It is highly sensitive, it's non-invasive, and it's very easy to perform, and it's very suitable for initial screening and follow-up after treatment. There is also what we have as the urea breath test, and so patients will ingest urea labeled with carbon isotopes. Now, if the H. pylori is present, it will produce urease, which breaks down the urea, releasing the labeled carbon dioxide detectable in the breath. And this test is highly accurate. It also confirms active infection and can assess treatment effectiveness. Now, another part of the H. pylori testing is serology, through collecting blood samples to detect antibodies to H. pylori. However, H. pylori, the antibodies persist long after the infection is cleared. Well, the tests cannot distinguish current and past infections, and making it less useful for diagnosing the active disease. Now, as far as the pre-test preparation here, make sure that you're going to test or you're going to advise the patient to avoid taking the PPIs, antibiotics, bismuth compounds for at least 2 weeks before the testing to prevent false negative results. They need to be taught to refrain from taking any food or fluids for at least 4 to 6 hours before the urea breath test. And also we're going to have to include teaching the patient on how to properly collect their stool specimen hygienically that is needed for the stool antigen testing. And we're going to have to inform the patient about the blood draw whenever there is a plan to check the H. pylori through the blood samples. Now, as far as the post-test, the patient can generally start any medications or restart their medications that were previously withheld before the test unless otherwise directed. And there's also a need for follow-up testing or follow-up appointments. Also making sure that they are aware of what the results are, and also maybe the need for more antibiotics or other treatments if the H. pylori infection is confirmed. Now, there is another testing. We have the serum gastrin measurement, which is indicated for the Zollinger-Ellison syndrome, or the ZES. This is basically a syndrome. And the ZES itself, the Zollinger-Ellison syndrome, involves a gastrin secreting tumor, or what we call as a gastrinomas, that will cause excessive acid production. It can also lead to severe and recurrent ulcer. Now, the role of the gastrin levels, elevated gastrin levels, it will help confirm the ZES, or the Zollinger-Ellison syndrome, and also it will help confirm the cause of the ulcers, particularly when the ulcers are refractory or to the standard treatments. And when we are going to place a patient into this kind of testing, the patient should at least fast for at least 8 hours before the blood draw, and the need to refrain taking any medications such as the PPIs, H2 receptor blockers, for at least 1 to 2 weeks before the testing, if possible, because these can artificially elevate the gastrin levels. And we need to inform the patient that this is a simple test that will involve the blood draw to evaluate the gastrin levels. Now, as far as the post-test care, we need to monitor the patient for any possible venipuncture site bruising. Their diet can resume as usual, and activities can immediately resume after their testing. Now, talking about the different management here or modalities in the treatment of peptic ulcer disease, we will require them to make sure that they can modify their lifestyle. That is really huge, by avoiding those irritants such as the NSAIDs, alcohol. We have also to encourage to stop their habit in smoking, also reducing stress, avoiding eating before bedtime, and also they should adhere in taking their medications, especially with acid suppression therapy. We already have those as the PPIs, the H2 receptor blockers, antacids, and also we need to eradicate the H. pylori infection once it is identified. Could be through the use of the triple therapy, such as the PPI, amoxicillin, clarithromycin, or the quadruple therapy with the use of the PPI, bismuth, metronidazole, and tetracycline. And also with the cytoprotection, which is going to involve the use of cytoprotective agents, which will enhance mucosal defenses and also protect the stomach lining from injury. And these are your sucralfate and the misoprostol. Now, on the other hand here, we have the surgical management for the peptic ulcer disease, and this can include the total gastrectomy, which is a form of a last resort procedure, and this is performed when the entire stomach is severely affected by the ulcer disease or has significantly malignant changes. And by removing the stomach and the connecting the esophagus to the small intestine, such as the jejunum or the duodenum, it will also eliminate the acid secreting areas that contribute to ulcer formation. And the total gastrectomy can also address complications like intractable bleeding, perforation, or maybe cancer risk associated with long-term cancer. Now, we have another procedure. We have vagotomy, which is going to help reduce acid secretion to treat or prevent gastric ulcers. And so we know that the vagus nerve can stimulate the release of the stomach acid, which can also worsen the ulcers. And by severing this nerve, acid secretion is going to be significantly reduced, which will help prevent further acid, or which will help further prevent ulcer formation. Now, we have another surgical procedure, gastric resection or the antrectomy. And so take note that the antrum of the stomach is the primary site where gastrin, which is the hormone stimulating acid production or secretion, is actually produced. And so removing the lower portion of the stomach can reduce the gastrin production and overall acid secretion, so to prevent recurrence. Now, we have the gastroduodenostomy or Billroth one, and this is used when the ulcer is located in the lower stomach, or let's say proximal duodenum, and needs to be removed. And so connecting the remaining stomach to the duodenum will restore normal flow of food while removing the ulcerated area. Now, we have another procedure, which is the gastrojejunostomy or Billroth 2. This is going to be done when the ulcers or scarring can obstruct the normal passage of food through the duodenum. And the connection between the remaining stomach to the jejunum can also bypass the duodenum, and it will reduce acid exposure and allowing the food to flow freely. Now, we have the pyloroplasty, which is going to cause enlargement of the pyloric opening. It will help improve the passage of the food and also reduce gastric stasis, which can exacerbate the ulcer formation. And so this is another procedure that is also combined with vagotomy to manage both gastric production and gastric emptying. Now, we are going to include here the different nursing actions after the patient has completed those surgical procedures. So included is to make sure we are monitoring the vital signs more frequently, regularly, to detect any complications such as hemorrhage or infection. We're going to place them in a Fowler's position to enhance comfort and also to promote drainage and to check for fluid and electrolyte balance and replace as needed and as prescribed, and also to monitor their intake and output carefully, and to make sure that we are also assessing their bowel sound to monitor for any return of the gastrointestinal function, and to also check for the nasogastric tube suction to ensure that there is proper drainage and to avoid complications. And take note that we're not supposed to remove or irrigate nasogastric tube unless specifically prescribed. Now, make sure that the patient is kept NPO for about 1 to 3 days until the peristalsis returns, and their diet will usually be advanced when the bowel sounds return, and gradually advancing their diet from NPO to clear water and eventually to 6 small bland meals per day as prescribed. Now, we also need to monitor the patient for so many post-op complications that may arise. Could be hemorrhage, could be the dumping syndrome, which is manifested by nausea, vomiting, cramping, diarrhea after eating. Also diarrhea, hypoglycemia. We're going to have to check the blood glucose levels carefully. Reflux of the bile, and also vitamin B12 deficiency, which can occur in the long term. So we're going to have to assess the patient, monitor them for any signs of pernicious anemia, maybe neurological manifestations. We know that this is going to be a common complication as part of partial gastrectomy, which will affect intrinsic factor production. Now, for the nursing process, or for monitoring the patient for other complications, rather, there's many actually, but on top of that, we have the dumping syndrome, which is basically the most common complication that may arise after any of those gastric surgeries. Okay, we have the Billroth 1 gastrectomy, Billroth 2. So those procedures can actually lead to this disorder, which is basically the rapid passage of food contents from the stomach into the small intestine. It will typically follow right away once they start ingesting food items. Now, what are the manifestations of the dumping syndrome? Well, of course, there's going to be GI symptoms, and namely these are nausea, vomiting, abdominal fullness, cramping, diarrhea. And if you're going to monitor their vital signs, the patient will have tachycardia, palpitations, and they will manifest the perspiration, weakness, dizziness. Those are the autonomic manifestations of the dumping syndrome. Berberigme is the presence of the loud gurgling sounds due to the increasing bowel activity. So take note of those. Now, for the nursing actions, what are we going to do for a patient that will be having the dumping syndrome? Well, we're going to need to make sure that they're able to maintain fluid and electrolyte balance due to the diarrhea, vomiting. We also need to check their vital signs, especially heart rate, blood pressure, in order to assess for tachycardia and hypotension. And also we need to prescribe antispasmodic medications to slow down the gastric emptying and also to prevent cramping. And we need to monitor the patient for any signs of any nutritional deficiencies, especially vitamin B12, and we're going to have to manage them accordingly. Now, as far as the positioning here, we're going to have to encourage the patient to rest in semi-recumbent position after their meals to minimize the symptoms of rapid gastric emptying. Now, for the parameters to monitor, what are we going to be looking at? Well, vital signs, for one, such as the blood pressure, heart rate, temperature will be our reference values. We have a GI manifestations. We have frequency of severity of diarrhea, maybe nausea and vomiting. So these are things that we need to keep an eye on. We need to look into the patient's hydration status, make sure that you are doing the intake and output regularly, and also keeping a close eye on any signs of dehydration. have to look into their electrolyte levels, especially the potassium and sodium, because these are easily affected by the vomiting and diarrhea. Also, their nutritional status, make sure that the patient is meeting their nutritional needs, particularly in terms of protein, complex carbohydrates, or the intake of fiber as well. Now, what are we going to do here as far as patient education? Well, we are going to make sure that the patient will start implementing, avoiding those caffeine containing products. Also focusing on high protein foods and complex carbohydrates like oatmeal, whole grain foods that are rich in fiber, and also to gradually increase their intake of fiber as tolerated, and to make sure that they are avoiding those high sugar foods such as candy, syrup, sodas, fruit juices. And instead of 3 large meals, make sure that they will have 5 to 6 smaller meals throughout the day. And also to avoid drinking fluids with meals, and instead consume liquids between meals. And so if dairy products can worsen their symptoms, they should also be avoided. And make sure that our patient will be laying in a supine position right after the meal. They will assume that positioning in order to slow down the gastric emptying. Now, another client education that should be included here is to adhere to their monthly injections for the vitamin B12, if it's going to be subcutaneous or intramuscular injections. Also with the use of antispasmodic medications to delay the gastric emptying as well. Now this time, we will be talking about the different complications of the peptic ulcer disease, and part of that is the perforation. This is an acute, severe abdominal pain wherein there's going to be possibly signs of peritonitis that can be observed. Maybe there's going to be abdominal rigidity, tenderness. There's going to be guarding. And also with their hemodynamic status, they are somewhat unstable. They will have hypotension, tachycardia, and these will indicate that they are probably going into shock. Now, what are the diagnostic tests that will support the perforation diagnosis? Well, one is the upright chest X-ray, which will reveal free air under the diaphragm, which is a hallmark of perforation. The use of the CT scan of the abdomen, which is the most sensitive, can also detect the free air and also localized fluids, confirming the perforation. Now, what is the management or the treatment for this one? Well, we need to stabilize the patient's vital signs. Their hemodynamic status should be monitored, making sure that we have frequency in checking their blood pressure, heart rate, and also oxygenation. We're going to have to ensure that the patient remains NPO and also receiving IV fluids, antibiotics to restore the intravascular volume and also to prevent dehydration or shock. And also to consider the administration of the isotonic fluids, such as the normal saline or lactated Ringer solutions. Now, why is there a need for antibiotics here? Well, it is done to combat the peritoneal infection and also to reduce sepsis risk. Now, what are we going to do? What else are we going to implement in a case of a perforation? Well, we're going to have to prepare the patient for emergency surgery to close the perforation and also to address the underlying cause. And so they might undergo different procedures, maybe highly selective vagotomy or the truncal vagotomy with pyloroplasty. And the parameters to monitor for this patient with a perforation should be based on the patient's vital signs. Make sure that their temperature is stable, not greater than 38.3, or their heart rate should not be tachycardic here. So if they're going to be elevated in their temperature, heart rate, respirations, those are not good signs. They basically can represent that the patient may be in a shock. And also when their saturation can also drop due to the lack of circulating fluid volume. Hypotension can do that. Now, the patient here might be going low in their diastolic and systolic blood pressure, let's say less than 90 mmHg, or let's say the mean arterial pressure is less than 65, despite their being resuscitated through the use of the IV fluid. So the patient's neurological signs changes should also be monitored. There's going to be some changes in their state. Maybe they're going to become confused, agitated, lethargic due to the reduction in the cerebral perfusion. As far as the gastrointestinal signs and symptoms, they might experience severe abdominal pain or distension, or could be absence of the bowel sounds and might indicate paralytic ileus from peritonitis. We also have to look into the patient's laboratory, such as the white blood cells and the lactate. Take note that there could be elevation of the white blood cells due to the infection, and the lactate levels can also increase greater than 2 milliosmoles per liter, which will suggest that there is hypoperfusion of the body tissues. And also take a look into the organ dysfunction. So we were going to take a look into the creatinine levels to check for their renal function, look into the liver enzymes, bilirubin, to check if there's going to be hepatic injury, or let's say the prothrombin time or the partial thromboplastin time, if there's going to be other changes caused by the hypoxemia and shock. Now, also take a look into the patient's urinary output. There's going to be significant oliguria, which is less than 0.5 mLs per kilo per hour, and this is caused by the lack of blood supply to the kidneys due to the hypotension. Maybe signs of peritonitis. There's going to be abdominal rigidity and guarding, rebound tenderness on palpation. Now, take note that the manifestations are not just limited with those, but patients may also manifest some cool, clammy skin due to the peripheral vasoconstriction and the poor perfusion in severe sepsis, or it could be due to the severe or septic shock. So you might see those mottling of the skin, or let's say cyanosis, which are basically late signs of circulatory collapse. Now, another complication that we have is the gastrointestinal bleeding, which is basically going to be manifested maybe by slow bleeding. And so this can lead to manifestations of anemia. So the patient might have fatigue, pallor, weakness, or maybe if their bleeding is somewhat kind of rapid, this might cause some hemodynamic instability. Their blood pressure might be low, they might be tachycardic, palpitations may happen. Hematemesis is also common, wherein there's going to be vomiting of blood, and this is indicating upper gastrointestinal bleed. And also melena, which is the presence of the black tarry stools, which signify that there's also presence of digested blood. Now, what are the diagnostic tests that will support gastrointestinal bleeding as a complication to the peptic ulcer disease? Well, we have the stool guaiac test. This is to detect for occult or hidden blood in the stool. And so we also have to prepare the patient for the upper GI endoscopy, which will identify the bleeding source, and also to perform cauterization or injection therapy to stop the bleeding. And the GI bleed can also be managed by stabilizing the vital signs. Then this is the priority. We have an issue on circulation, and so we want to make sure that the body's blood pressure is able to maintain perfusion in all bodily organs, and make sure that the heart rate is also monitored, oxygenation. We're going to have to take a look into the mean arterial pressure at most. And also we have to treat the patient through the use of the PPI, the octreotide, and the IV. Now, why the IV? Well, we need to restore the intravascular volume and also to prevent dehydration or shock. And we're going to have to use the normal saline or possibly the lactated Ringer solution, and administer the PPI, such as the pantoprazole IV, and also the octreotide, which is going to promote vasoconstriction, which will help control the bleeding. We're going to have to anticipate the administration of the blood products as well if there is going to be acute bleeding, especially if there is massive hematemesis or if there is significant drop in the patient's hemoglobin and hematocrit. So possibly using more than 6 units of blood. We're going to have to keep the patient on fasting mode to keep the to prevent aspiration and also to prevent for any endoscopic procedure, and in order that they can undergo that cauterization to treat the source of bleeding. And what are the parameters to monitor that should be included in the GI bleeding complication? Well, we're going to look into the patient's vital signs first and foremost. So make sure that you are going to watch for any deviations from normal, especially with heart rate, blood pressure, temperature, respiration, oxygen saturation. We're going to have to watch for any signs of shock. Now, hemoglobin and hematocrit levels need to be checked as well, especially coagulation studies to assess any blood loss and also to check for the patient's response to the treatment. Now, we also need to watch for the color and the consistency, the frequency of the patient's stool, and also to evaluate ongoing blood loss, and also to check for the effectiveness of the treatment that we are providing to the patient. Now, take note that there is another complication to the peptic ulcer disease, which is the gastric outlet obstruction, which is going to be manifested by nausea, vomiting, especially vomiting of the undigested food or poorly digested food. There is also feeling of fullness and early satiety. This can also lead to discomfort after having a small meal. Now, the patient here will also end up with a weight loss due to the reduced nutrient intake. And the following diagnostic tests that you should expect to be done are the following. Could be the barium swallow to visualize the obstruction and also assess the stomach structure. There's also the upper endoscopy. I'm not going to elaborate about that this time. We also have the saline load test, which will measure the stomach's emptying ability. And so the medical provider here will be instilling at least 750 mLs of saline via nasogastric tube and will aspirate after 30 minutes. And so a positive test is an aspirate volume of greater than 400 mL. So basically, the patient is not able to empty the saline into the small bowel. So it's quite retained in the stomach. Now, what is the management of the gastric outlet obstruction? Well, we're going to have to maintain naso insertion and maintenance of the nasogastric tube and place them into the suction equipment to decompress the stomach. We need to replace any fluids and electrolytes that have been lost, and also to provide them the supplemental nutrition, particularly if the obstruction is long-standing, and we have to prepare the patient for any surgery. And this is going to be required in about 75% of the cases for definitive treatment. Now, what are the parameters to monitor in a patient with a peptic ulcer disease? Well, we are going to measure electrolyte levels. Intake and output needs to be done religiously. Also to monitor the weight, and also monitor for electrolyte levels and nutritional status to check or address ongoing deficits. Now, this time we will be talking about the nursing process here, and the nursing assessment will start with the assessment, of course, assessing the characteristics, the aggravating, relieving factors, and the pattern of the pain. We need to assess the vital signs for any signs of bleeding, orthostatic hypotension, maybe other complications. We need to assess eating patterns and also the history of their medication use. Maybe they're using NSAIDs, aspirin, or steroids that may end up hurting their stomach. Also, we're going to have to conduct psychosocial and physical assessment. And as far as the nursing diagnosis here, we need to go back into the nursing diagnosis, because these diagnoses will actually guide you in picking the priority problems in order for you to target the issues that you're currently seeing in a patient in the NCLEX especially. Now, the first nursing diagnosis or nursing, the top priority here is the deficient fluid volume related to the hemorrhage. It could be the acute pain secondary to mucosal erosion or hypersecretion, the diarrhea related to the GI bleeding, and maybe imbalanced nutrition, less than body requirements, or could be deficient knowledge regarding treatment. Now, for the nursing actions, the priority here is to avoid fluid volume deficit. So we need to monitor the patient's intake and output, stools, their hemoglobin, hematocrit levels. We're going to have to administer IV fluids, could be blood products, medications, and prepare the patient for lavage or surgery. Now, pain control is also important. So we're going to administer the prescribed pain medications and avoid the use of irritants such as the NSAIDs. Now, we also need to administer the H2 receptor blockers, the PPIs, barrier protectants, also we need to decrease their incidence of diarrhea, monitor their pattern of their elimination, administer antidiarrheals. We also need to maintain their nutrition. So we can do this by providing small frequent meals, nutritional supplements, and administer parenteral nutrition if needed in severe cases. Now, part of the education here will be to help the patient recognize those signs of bleeding, follow the treatment plan, and also adopting healthy lifestyle changes. And also, we need to teach them regarding the recognition of the complications such as bleeding, and also to promote healthy lifestyle modifications. Now, we'll be talking another topic here, which will be all about hernia, hiatal hernia. And so this is a condition that occurs when there is a portion of the stomach that will start to protrude through the diaphragm, or let's say the diaphragm hiatus into the thoracic cavity. And so there are different types of the hiatal hernia. One is the sliding hernia. And so this is going to happen when the stomach and the gastroesophageal junction will slide upward into the chest. And this is the most common type. We also have the paraesophageal hernia, which is we call as the rolling hernia. And this occurs when part of the greater curvature of the stomach rolls through the diaphragmatic defect. And these two are often caused by the weakening of the muscles due to aging, or it could be caused by esophageal carcinoma or trauma, or maybe after a surgical procedure. Now, the patient will be complaining of heartburn. They could be complaining about chest pain, maybe regurgitation or vomiting of food that was just ingested. Also, they're going to complain about difficulty swallowing, maybe fullness, worsening of those following symptoms when they start lying down. Now, as far as the diagnostic testing here, barium study will be used to help outline the hernia on X-ray, and also with the endoscopic type of procedure, upper endoscopy will help visualize the defect in the esophagus. Now, take note that the complications of the hiatal hernia can include aspiration of the reflux contents. It could be ulceration or hemorrhage. It can lead to the inflammation of the stomach lining, gastritis, and it can also lead to the stricture. There's going to be narrowing of the esophagus, or it could be trapping of part of the stomach in the chest cavity. This is what we call as the incarceration. Now, what are we going to do when the patient has hiatal hernia? Well, the lifestyle modification is very important here. We're going to have to elevate the head of the bed about 6 to 8 inches, or let's say 15 to 20 centimeters. And this is going to reduce the nighttime reflux. We also need to administer the antacid to neutralize the stomach acid, and make sure that they are getting the H2 receptor antagonists, which are the cimetidine, ranitidine, if the patient has esophagitis. Now, take note that surgical repair will also be considered if the symptoms are severe or the complications can happen. And so The treatment can include the laparoscopic fundoplication, which is the most common procedure. Now, what are we going to do here, especially in the case of hiatal hernia? Well, reflux prevention is very important. So this can include having the patient eat smaller, more frequent meals, avoiding caffeine and alcohol, which can stimulate gastric secretion. We're going to have to have the patient refrain from smoking because these can worsen the reflux, avoiding fatty foods that might delay the gastric emptying, and also making sure that our patient is not going to lay down right away after the meal. So they have at least to wait about an hour before doing that. And also to lose weight and avoid bending from the waist, which can aggravate the hiatal hernia. And we want to make sure that we're also educating the patient about reporting right away if they start feeling that acute chest pain. Why? Well, the acute chest pain might be a sign that there is incarceration of maybe a large paraesophageal hernia, which is going to require urgent attention. So they need to have immediate attention for this one right away. And so we've gone through the GERD topic. We have had the gastritis topic as well, peptic ulcer, hiatal hernias. So I hope that you have solid grasp on these concepts, and which is going to be really huge topics, especially in the preparation for your NCLEX. And so you need to remember this, that every bit of this information can make a real difference in how you're going to take care of your patient. And you got to keep up the great work in reviewing the concept, and you don't stop learning. And so I'll see you again in part 2 of the gastrointestinal disturbances. Thank you. And I thank you so much for your time, and I'll see you again.